Most of us have a vague idea what probiotics are, like beneficial microbes. But I think the strict definition is live microbes that, when administered in adequate amounts, and confer a health benefit. Yeah, and I think you could see that as having a few different components of that definition. Is one, they've got to be alive. So if you're having a supplement that contains dead bacteria, and it can still be very healthful, but it won't be a probiotic at that point. In fact, it should be termed a postbiotic, technically speaking. The other aspect is that it confers a health benefit too. And there's certain parts of the world and certain research scientists in this field who take that very seriously. Whereas if you have a strain of Lactobacillus acidophilus or Lactobacillus rhamnosus that has no research on it at all, they wouldn't call it a probiotic. They'd be like, okay, that's a bacterial strain that may or may not have any sort of therapeutic benefit.
Hey, this is Ari. Welcome back to the Energy Blueprint podcast. With me today is a very special guest, Dr. Jason Hawrelak. He is, without a doubt, one of the premier, most world-class, most expert of the experts in the gut microbiome. So in a world of people, lots and lots of people who are claiming to be gut health experts, this is, in my opinion, the premier gut health microbiome expert, one of them certainly, in the world, on planet Earth. He is not a public-facing influencer where people in the general population would know him, but he is widely known among actual gut health experts and physicians and clinicians, conventional and functional medicine, doctors who specialize in gastrointestinal and microbiome health. He is extremely well known, and he offers coursework for those practitioners. He's often an educator to those gut health experts and training them in their knowledge of the microbiome. He's also a clinician. He's also a professor. He's also a researcher. He's written over 20 textbook chapters in actual clinical textbooks meant for training professionals in this domain of gut health and microbiome health, and is really la creme de la creme of gut health experts. I've personally had the pleasure of taking graduate level coursework under him, and this podcast episode was actually recorded, the one that you're about to hear, was actually recorded about a year ago, and we haven't released it since then for a reason I'll explain in a moment here. Right after I took his coursework, because I was so impressed with his knowledge, I essentially reached out to him and said, hey, I've got this new brand that I'm about to release. It's called Human Optimization. It's going to be featuring the world's top experts in these different domains of knowledge, whether we're talking about brain health or cardiovascular health or mitochondrial health or gut health and microbiome health or fitness, and many other aspects of health, as you guys are going to discover in the coming months as I build this new brand out more and more. The new brand, Human Optimization, has officially launched. And here's the reason that you're just now getting this podcast that I recorded over a year ago with Dr. Hawrelak. It's because I reached out to him and said, would you like to be the gut health and microbiome expert that is featured on the Human Optimization brand? Fortunately, he said yes. And since the recording of the podcast you're about to hear, we have since built out a whole course on gut health and microbiome optimization. And that course, as of a few days ago, just launched under the Human Optimization brand. You can find it at humanoptimization.com. It is an absolutely phenomenal course. Now, I want to say that this is not a course like his typical courses that are meant for practitioners, training practitioners and clinicians, and the nitty-gritty of the very advanced science of this species of bacteria and that species of bacteria, and here's how you analyze your patient's microbiome tests, and here's what you do in this scenario, and here's what this test result indicates, and maybe you're dealing with this kind of dysfunction, here's what to do next, and here's the protocol for this condition and that condition. This is not a course meant for practitioners and clinicians. This is a course meant for the general population to learn the basics of gut health and microbiome optimization from really one of the world's top experts who is debunking myths, who is simplifying the science, who is giving you the actual science on this topic. And I can tell you that even for myself, prior to learning from Dr. Hawrelak, I was under a lot of misconceptions. I had a lot of bad information on gut health that I had learned from various other people out there. And this is really the reason why, again, that I wanted to partner with Dr. Hawrelak to create this microbiome optimization course for all of you guys. So I would highly encourage you to check that out. Again, you can get it at humanoptimization.com. Go to programs, get the gut course. It's just packed with gold nuggets of information that are potentially life-changing. Not only if you are currently struggling with gut health problems, but also if you're just interested in optimizing your health, disease prevention, and longevity. We now know, of course, as you're going to hear in this podcast, we have a body of evidence that's emerged over the last mainly 20 years, especially, that has connected gut and microbiome health with just about every other aspect of health imaginable. We know there's a gut-brain axis. We know there's a gut-immune axis, a gut-skin axis, a gut-muscle axis, a gut-mitochondria axis. This connects with our energy, our mood, our brain function, our metabolic health, our risk, our body composition, how fat and muscular we are, our performance, and every aspect of health that you can imagine. So we know, and I'm sure you've heard, that gut health and microbiome health are extraordinarily important to overall health and disease prevention and longevity and quality of life, things like energy and mood and brain function. So if you're interested in those things, in optimizing your health and longevity and energy, I would strongly encourage you to learn this information. Again, we just launched the course under humanoptimization.com, and right now it's on sale for $297. The price is going to go up here in, I think it's in a week or 10 days or so. The price is going to be bumped up to $500. So go grab yourself this course if you are a health geek like me and you want to learn everything you can possibly do to optimize your health, your energy, longevity. I would strongly recommend going to get this course. And I think, what I'll say is, with no further ado, let's get into this podcast, and you will see, as you listen to Dr. Hawrelak, humble as he is, soft-spoken as he is, just how knowledgeable and how brilliant he is when it comes to this area. So I think, I'm not trying to do any hard selling here. I think you're going to be convinced just listening to him what an amazing expert he is on this topic. So go to humanoptimization.com, get the program if you are a health geek looking to optimize energy, health, and longevity. And with no further ado, let's get into this podcast on gut health and microbiome optimization with Dr. Jason Hawrelak.
Thank you for having me. Thanks for those kind words too. I'm humbled. I think it's the right word. Yeah.
Yeah. So I think as a general starting point, broad question, maybe as an entry point, especially given this is the Energy Blueprint podcast, we could talk about the relationship between gut health and energy levels and some of the key mechanisms there, maybe the gut mitochondria axis or any other aspects you want to talk about, the gut brain axis, any of the sort of key mechanisms that you see linking gut health with energy levels.
Okay. That's a great way of introducing the area, actually, because I think for me, when I'm looking at this, and I'm looking at gut health in general, there's probably three components, broad components I look at. Number one would be gut motility, and how long it's taking food to go make its way through, and essentially around colonic motility, or more likely lack thereof. It's when people actually have, fecal loading or constipation. Because when we get the situation where fecal matter is in there for a fair period of time, and for some people this can be 10, 15, 20 days actually transit time from mouth to toilet bowl, as I tell my patients. And I think this is an easy thing you can test at home, and I think everybody should be totally onto this and be aware of this. But you can have some corn on the cob or some red quinoa, black quinoa, or even some green peas. Don't chew them particularly well, don't choke, but don't chew them all that well. You want to be able to see them come out the other end. Just take note, write down when you actually ate it. Keep track and look at your bowel movements in great detail over the coming days and see when it starts coming through. And I've had patients who were doing, a lovely type 4 stool, which is a Bristol stool, which some people would call the perfect poo, every single day, never missed a day. And it took 10 days for the corn to come out the other end.
Whoa.
And I've had other patients who were only pooing every 2 or 3 days. It was 26 days before the corn came out the other end.
Wow.
And if you could imagine how much they're reabsorbing from that. And it's something that, Hippocrates said, death sits in the bowels, or essentially all disease begins in the gut. And I think this is one of the concepts around that, is that when we have, and older naturopaths used to call this bowel toxemia, in that we've got this sort of old fecal matter there that's constantly leaking bacterial toxins into the system. So that's one of the key things we look at, okay, is like looking at transit time. And if transit time is slow, then we're obviously absorbing through the colon mucosa a lot more of those toxins. And particularly what I'm referring to is endotoxins, or also known as lipopolysaccharide, which is part of the the cell wall gram-negative bacteria, which is a group of bacteria in the gut. So that's one consideration, is transit time. 2 is microbiome composition. Yeah, and this is also fits in with the endotoxin or lipopolysaccharide, because people's ecosystems they're all unique. My ecosystem will not look like yours. You could take like 1,000 people, and there'll be some similarities, obviously, but there'll be marked differences. And just like your fingerprint's unique, your microbiome signature is unique, and more similar to your siblings and your mom, probably anyone else in the world, but still quite different. But within that sort of individual composition, there'll be certain ecosystem traits that you'd see as pro-inflammatory, depending on that composition. And if your ecosystem contains greater amounts of what we call gram-negative bacteria, but a specific grouping of that called proteobacteria, they're much more problematic from an inflammatory perspective. 80% of the cell wall structure of gram-negative bacteria is lipopolysaccharide, or endotoxin. And this isn't a toxin in that the bacteria is secreting it to make us ill. It's like, we grow hair, we grow fingernails, it grows lipopolysaccharide. It's just what it does. And just when they die, they kind of release that lipopolysaccharide into your gut lumen. And now some people only have, I had patients yesterday where they 0.4% proteobacteria. And I've had other patients who are 50% proteobacteria, to probably give the 2 extreme ends of that. And most people are not in either of the 2 extremes. But the amount of proteobacteria that's present has a huge contributor to potential inflammatory load, essentially, because when you've got greater amounts of proteobacteria present and other gram-negative bacteria, and there's other groupings like Bacteroidetes or Verruca microbia, that also have endotoxin involved with that they grow too, but it's far less inflammatory. It's really proteobacteria that we really clue in with, because it's a super inflammatory compound. Yeah. So we look at the composition there, and we know that lipopolysaccharide essentially works as it's an immensely pro-inflammatory agent. It can cause damage to the gut itself, so cause a leaky gut. But when it reaches the circulation, this is where we know it can impact things like blood sugar regulation negatively, decreases insulin sensitivity. It can damage the blood-brain barrier. It changes what neurotransmitters we produce. It causes inflammation in the brain, and it interferes with mitochondrial function. Yeah, so we've got this situation where we've got these bacteria that are releasing these toxins, and some people are releasing a lot more of those. And there's certain dietary choices that we make that actually can enhance or decrease the absorption of that endotoxin as well. Yeah. So you'd see that you're having these sort of mitochondrial poisons that you're absorbing 24 hours a day. And then sometimes with certain meals, you get a spike of lipopolysaccharide hitting the bloodstream. And that's termed endotoxemia now, or metabolic endotoxemia, to be a bit more specific. So that's the other aspect, is looking at microbiome composition from a pro-inflammatory perspective. But then conversely, we have other species in the gut that we would see as having the opposite effect of producing anti-inflammatory compounds. And those have capacity to promote gut healing. So you might put, species like most people are familiar with, like bifidobacteria, is one that we would see as having anti-inflammatory sort of gut healing qualities. Yeah. There's others that are less well known, like Akkermansia eosinophilia is also a species that we see as helping promoting gut health and gut integrity, and subsequently helps with blood sugar regulation and even helps determine your metabolic rate, but which I think is super cool too. But there's another bigger group that we call butyrate producing species. And I think you can see butyrate as almost the counterpoint of lipopolysaccharide, and that butyrate has a healing anti-inflammatory effect in the gut. It is the main food source for your colon cells. And many people are we've been aware of that aspect of things for a long time. But I still think it's pretty amazing to think that we've evolved reliant on bacterial production of this compound to feed certain group of our cells that are really key for our good health. And the issue here is if we don't have enough butyrate producing species, we don't make that much butyrate as a consequence of that. And that any butyrate we do make in the gut is sort of avidly consumed by our colon cells, and none of it reaches the sort of body-wide circulation. It's only when we sort of make enough butyrate that it exceeds our sort of colon cells capacity, that butyrate reaches the systemic circulation, floats through the area, and there we get the anti-inflammatory effects body-wide of butyrate. And it has a healing effect on the blood-brain barrier, decreases neural inflammation, and improves mitochondrial function, improves blood sugar regulation, improves metabolism. It's a pretty amazing substance, actually, butyrate. The more we research it, the more stunning we actually find that it is. And we've got these little factories in us, all of us do. The population can vary dramatically too, from, the lowest I've seen is 2% of an ecosystem being butyrate producing species. And the highest I've seen is like 65%. So again, a huge variation there that can determine how much of an anti-inflammatory effect we're getting from that microbiome versus the pro-inflammatory effect that we get when it's more proteobacteria and more lipopolysaccharide. And I think the third thing to look at is gut integrity. So when the gut is what we call a leaky gut or intestinal hyperpermeability, we have more of the lipopolysaccharide that actually leaks through into our systemic body-wide circulation, and we get more of the negative aspects to our health and essentially inflammation that goes everywhere. But people will have their own sort of weak areas where I think that inflammation will become more manifest, and that will differ a bit per person. Where some people with endotoxemia will start developing insulin resistance. Some people will start developing weight gain. Other people I think it's got a role personally with autoimmune conditions as well. Some people get brain fog, and we know that endotoxins play a pretty pivotal role with something like Alzheimer's disease and cognitive decline. There's been some very cool research where they've done autopsies of, the brains of Alzheimer's patients, and they're super rich in endotoxin. And people who do not have Alzheimer's, it's not rich with endotoxin, like it's not in their brains, nowhere near as a degree. So I think for me, it's those three areas that I'm always looking at. It's like, what's gut integrity like? What's the microbiome composition look like? And what's your transit time? Because alterations in any of those three things can certainly play a pivotal role with essentially your inflammatory status. And I think that flows into cognitive function, that flows into just level of energy, I would suggest two for that matter. But then if people have got 2 out of 3 or 3 out of 3 not working well or imbalanced, then we get major problems occurring.
Yeah. Good stuff. I want to mention on your number 2 point about short chain fatty acids and butyrate. I interviewed Datis Karazian, Dr. Karazian recently, a few months ago, and he actually listed butyrate as his number 1 compound for brain health as far as supplements he was recommending.
Yeah.
I was a bit surprised by that. I was expecting maybe curcumin or polyphenols or something like that. Centrophenoxine, who knows, vinpocetine, but he went with butyrate, and he just raved about the effects on brain health in particular. And this is, widely regarded as one of the world's top brain health experts who was saying that.
That's very cool. Yeah. And I remember there was a paper published, I think it was 2016, that was one of the earlier ones in a neurology journal talking about how do we improve brain health? Let's give people fiber. And it's like, that was pretty mind blowing. And I think seeing that in a mainstream neurological journal was great, because it just means that, it's people particularly the top research experts are totally clued into this, but it's the message is seeping out. But I think that's pretty amazing that that's their number one. And we just have, and I think it's so cool because we actually have these butyrate producing factories already there. We just have to make sure that we're feeding them to actually get that benefit.
Yeah, actually, that's a point I want to circle back to: fiber and butyrate consumption later in the podcast. So let's talk about probiotics. This is a huge area of passion for you and something you know a ton about. And I've already learned a ton from you on this topic, things that I didn't know. You know, for example, the importance of strain specificity. I was kind of blown away by a lot of the research you presented on that topic, which is something I've historically kind of brushed off as unimportant. I thought it was mostly sort of a marketing gimmick that people say, oh, you know, this strain of Lactobacillus rhamnosus versus that strain. I'm like, you know, they're the same species. How different could they possibly be? And I've seen from a lot of research that you've presented, they are very different in many cases. So first of all, can you talk about what a probiotic actually means? And then I want to talk a bit about some common probiotic myths and then the strain specificity.
Yeah, so most of us have a vague idea what probiotics are, like, you know, beneficial microbes. But I think the strict definition is, you know, live microbes that, when administered in adequate amounts, and confer a health benefit. Yeah, and I think you could see that as having a few different components of that definition. Is one, they've got to be alive. So if you're having a supplement that contains dead bacteria, and it can still be very healthful, but it won't be a probiotic at that point. In fact, it should be termed a postbiotic, technically speaking. The other aspect is that it confers a health benefit too. And there's certain parts of the world and certain research scientists in this field who take that very seriously. Whereas if you have a strain of Lactobacillus acidophilus or Lactobacillus rhamnosus that has no research on it at all, they wouldn't call it a probiotic. They'd be like, okay, that's a bacterial strain that may or may not have any sort of therapeutic benefit. So I think that's the other interesting aspect of that definition as well as adequate amounts. And this is where this does differ a bit per strain. And that there's some pretty amazing research on Lactobacillus reuteri strain DSM-17938, which is sold around the world as BioGaia. Okay, and it's often, the research studies often use 100 million CFUs, so colony forming units, so 100 million microbes. Yeah, and it gets these great results. And it's just not good for everything, but it's good for a lot of different things. You know, for viral gastroenteritis, preventing antibiotic-associated side effects, even prevention of SIBO in people who take proton pump inhibitors. You know, so a decent spread of applications, all at that very tiny dose. You know, where some people would go, oh, there's nowhere near enough. We have to give, 100 billion on 10 different strains to get any sort of impact. And it's like clearly not the case from research. And I think that's one of the probably flow into this particular myth that sometimes there's a mythology that we have to give mega doses, or it has to be mega, high potency multi-strain to get any sort of positive impact. And that's clearly not the case. And then we've got, hundreds of research studies showing single strains, even at, relatively low potencies of 100 million or 1 billion microbes having therapeutic effects clearly in the literature.
Very, very interesting. Okay. So, as far as strain specificity, can you give a few examples of how that plays out in some specific studies about specific species of bacteria for specific outcomes?
Yeah, and this is an area, like when I did my training, I trained at my naturopathic training was in the late 90s, and we didn't cover strains really at all. It was kind of like very superficially, and most of the stuff was talking about species. And it's only when I started delving into it, part of my PhD, was like, you become familiar with these new concepts of, I delved into prebiotics, which I really knew superficially, delved into probiotics, and it's like, oh my God, there's actually dramatic differences in terms of characteristics or qualities, never mind therapeutic actions of strains within the same species. And for those people who are less familiar with the concept of strain, I think a good analogy here is like breeds of dog. All dogs are Canis familiaris. They all have certain traits in common, but there are differences, but they're all the same species. Yeah. And with bacteria strains within the same species, we don't have the same physical characteristics that look different, but we know that we can subject them to different exposures and they will react differently. Like they can, some strains within a certain species will tolerate stomach acid and some won't. Some will tolerate bile, some won't. Some will attach to your gut, some won't. Some will stay in your gut for a few days, some will pass straight through. Just to name a few of those sort of basic characteristics that we're often looking for with probiotics, and that we've known for a long time. You can go back to research in the 1970s that we're looking at. Let's isolate 15 strains of Lactobacillus acidophilus and let's expose them to get stomach acid. And you could see even then that some strains could tolerate those things, some things did not. I think there was a study in 2010 where they took, I think it was 90 strains of Lactobacillus, I think from memory it was fermentum. And they said, okay, let's expose these 90 strains to stomach acid, let's expose them to bile, and let's see how many tolerate both those things well. And I think it was, from memory, it was 4% of those starting materials could actually tolerate stomach acid and bile, to the point that they could theoretically survive transit to the upper gut. The rest would have all died. Yeah, I think that's one of those clear examples. And there's, looking at another species, Lactobacillus butyrate. And there's certain strains of Lactobacillus butyrate that can produce an antimicrobial compound called reuterin. And reuterin is effective against fungal pathogens, is effective against bacterial pathogens. But we can't assume that all strains produce it, because they don't. Only some strains do. Even if it has the name Lactobacillus butyrate, it does not mean it produces reuterin. And those strains that do not produce reuterin are very unlikely to have the same kind of benefits from a microbiome alteration perspective, either against fungal dysbiosis or bacterial dysbiosis, as those that produce reuterin. And the strain that we know that's probably the biggest from the research base is the one I mentioned before, the DSM-17938, which is in BioGaia, which has got this cool study where they gave it to essentially kids who were taking a proton pump inhibitor, which is a class of medications that probably many of your listeners are familiar with. And gosh, a lot of people take in Western nations, it's huge, but because it suppresses stomach acid output. So it's used to treat reflux disease, essentially. And also peptic ulcer disease, but that's usually a shorter period of time. But for a high proportion of people who take this medication, they develop SIBO, small intestinal bacterial overgrowth. And there's some debate about how much that is, whether it's 50, 60, 70% of these people will develop it, but it's pretty marked anyway. So this study was okay, well, what happens if we give a probiotic alongside the proton pump inhibitor? Will it prevent SIBO from developing? And this is what the study did. They gave a placebo, they gave this particular strain of Lactobacillus butyrate, and I think SIBO developed in 56% of those in placebo group versus 6% of those in that probiotic group. And I think what's interesting here is that there's another study using a combination of two different probiotic strains at maybe 10 or 20 times the dose. Similar model, let's give it to people taking proton pump inhibitors. It did not work. It didn't actually stop SIBO from developing. So it's not something that all probiotics do, but this particular strain we know produces reuterin, and reuterin works against fungal and bacterial pathogens and prevented the overgrowth from occurring, which I think is, one of the things that's pretty amazing. And it means we just have to make sure that the strains that we're choosing for attacks has got the qualities and actions that we're after. One of the few studies that actually directly compared two different strains in the same study was for viral gastroenteritis, which is something that all kids end up getting. All of us will often get it from our kids is when they bring it home from daycare. So it's immensely common, this condition, generally short-lived, but it can result in hospitalizations and dehydration and death in kids, and often does still even in Western nations because of the dehydration aspect, even though it's not, directly causes death, it's more indirectly via dehydration. So having treatments that shorten the duration and decrease the severity are extremely welcome. So in this particular study, they compared these two probiotic strains, same species, Lactobacillus rhamnosus, one with L. rhamnosus GG, one with Lactobacillus rhamnosus lactophilus. Gave these kids either the two, and the kids that took the LGG, they got better 24 hours sooner. And 24 hours is big. If you've got a kid that's got vomiting and diarrhea, you will notice 24 hours less of vomiting and diarrhea. Yeah. And it also enhanced secretory IgA production, one of the main sort of immune markers, way the immune system is dealing with pathogens like viruses in the gut, whereas the other Lactophilus rhamnosus did not. So, and this is, again, same species, just different strains. And there's a lot more examples in terms of other characteristics that we could go into as well. But I think it's it is very clear if you look at the literature. It's definitely not a marketing thing. And I hear you, because I think there's a lot of practitioners, and I think this is partly because industry promotes that idea. Some in industry do. Generally, the companies that are
using
promoting
non-optimal
supplements
strains.
that don't have research. Yeah, that's right. That don't list their strains, or they use strains with no research base. So they don't want people to know about the strain specificity. They want to cloud the waters, and they do that effectively. Yeah, and this is something that I've been trying to bust for seriously 20 years. I've been trying to let practitioners, clinicians, and the general public, but mostly I work with training clinicians, this information so that they can really see through that, the cloudiness that's being put out there. Because the research is clear if you look at it, that there are generally big differences. Now, for certain conditions, it may not matter so much, where maybe the similarities of like their capacity of bifidobacteria strains to produce acetate, and that all of them probably will share within a given species, although there will still be differences in terms of how much they produce to certain food substrates, but they all produce acetate, for example. That might mean for certain conditions, it won't matter as much. And you might put, maybe post antibiotics, trying to help restore a bit of gut health, something, maybe it won't matter quite as much, in that case, because maybe just a change in pH is all that's required to help in that case. Now, that said, it matters heaps when we're actually giving it alongside the antibiotics, where we know that certain probiotics make no difference. Like there's this cool study that was published in the Lancet, it's a huge medical journal, in terms of reach and how high it is from an impact factor perspective. That used, I think it was 60 billion CFU of 4 different probiotic strains to try to prevent antibiotic-associated diarrhea. And I think it had like over 1,000 patients. It was like a big study. It did not work. Yet we've got other strains where you can give, I'll go back to that lactose-reuteri DSM 17938, 200 million CFU. It works to prevent antibiotic-associated diarrhea. So we know alongside antibiotic, strains definitely do matter, but there will be some applications where I think, probably after antibiotics, where we're just trying to change the pH of the environment to help indigenous populations that we want to support to grow back a bit more quickly, may not matter quite as much.
Mm-hmm. Got it. Okay, so the big picture summary of this is strain specificity, not just marketing gimmick, often matters in a massive way and can be the difference between something working exceptionally well versus not working at all, even within the same species. Sort of like a Doberman and a Chihuahua are the same species. One is a really good guard dog, one is not such a good guard dog.
That's exactly right. And some of this, like you might have a catalog or something that's good for certain tasks, but not good for other tasks. And that's what we tease out with research on these strains, is that one is good for antibiotic-associated diarrhea, but completely useless for depression, or one might be good for antibiotic-associated diarrhea and not good for preventing urinary tract infections, and then we've got that clear example of strains within species that are already out there. So I think that dog analogy is helpful in a couple ways.
Absolutely. It was helpful for me when you presented that. I was like, wow, yeah, I never really have considered that they're all the same species and they are radically different as far as their function. I have a couple of Australian cattle dogs, and they're built for a certain function, and they're not good for a certain function. If I want a dog to, if I'm laid out in bed, or I have an elderly person in my house who just needs a companion to sort of lay by their side in an apartment all day, this is a really bad choice of dog for that purpose. Because
it is. And I used to
out running around all the time.
Yeah, I used to have a red Kelpie, and they're bred to run like 60 kilometers a day or something like that. They're just like little battery cells. They just never run out of energy. So not good for keeping your elderly relative company.
Exactly.
No, but very good for the other tasks. Definitely.
Yes. Yeah. And it might be worth mentioning, so you're the head of research of Probiotic Advisor. This is a company that I learned about through you, and I signed up for, and I have been absolutely amazed by that. I didn't know a tool like this even existed, where I can go in and type in a particular condition. Like, for example, my 2.5-year-old, since we potty trained her, started suffering from some constipation, and started going, instead of going to the back, having a bowel movement every day, it became every 2 or 3 days. And so I can look up, probiotics specific to that function, or probiotics specific to hand eczema, or antibiotic use. How do you minimize certain complications when you're on antibiotics? And it brings up the search results of all the specific research on specific strains of probiotics that have actually been shown to be effective in that specific context. So it's an amazing tool that I didn't even know existed until I started taking your course.
Thank you. Yeah, it started off with just some paper documents. Is how that started. Seriously, probably in 2001. I first started teaching. When I started my research process, and I first started teaching, and it's like, okay, I'm going to pull together these resources, and in the end, with 3 different documents, and they had to be 30 pages long or 40 pages long, and it's like, okay, I need to put this into a searchable database rather than have it all on bits of paper in the old way. But I think we now have that capacity to really look at the research, and because the research has built up so much over the last 20 years that we don't have to guess, we don't have to take the supplier's word for it, which is what many people were doing before. It's like, this company says it's good for this. I'm like, no, don't. Look at the research. And this just makes it easier, because you can do a search of Medline. And I think we should still all be doing that frequently, but this is a tool that just makes things easier. You can just type in that condition, and it brings up the strains, and it tells you what products in Canada or the US or Australia contain those strains, just to again make things easier, because that's the added bit on top is like, this is a great strain, this great research study, but where do you get it? And sometimes those bits of information are not easy to come by.
Yeah, absolutely. Okay, so one other thing related to probiotics that I want you to speak to is colonization. I think this is also a widespread myth. People have the assumption they take a certain probiotic and they think it goes in there and it just starts colonizing the intestinal tract, and then starts reproducing. And so now you've got huge quantities of this particular species of bacteria. What is the deal with that? Is there any species that colonizes? I know this is probably something that you could talk about for 5 hours, but how could you sort of simplify into a few minute long answer?
Simplify, generally no. Generally, we don't get colonization from current generation probiotics. So we're talking about lactobacillus strains, bifidobacteria strains, even the E. coli strains we currently have, Saccharomyces probiotics, and I'd say the bacillus type strains too. They don't permanently colonize. They're all temporary visitors. And this has been clear for also like 40, 50 years. I think this is, for me, the interesting thing is that there's this conception that one of the 5 R points is re-inoculate, and people think that they can just take antibiotics and then just pop a pill and everything will be replenished from that and forever onwards. And it's good to know that that's not true. It's rubbish. It does not happen, because I think it makes you appreciate and care for that ecosystem differently when you know that it's actually, one, it is unique. It's yours, it's been passed down your family line, and we should respect it as such. And 2, that it's not as simple as that, and it's not reality. If we wipe out our bifidobacteria, we can't replace it with one in a supplement. It doesn't stay. And again, you go back 40, 50 years, it's like a good probiotic strain will last a week or 10 days in there, versus ones that just pass straight through, or ones that die in the stomach or small intestine. And we've had studies showing this time and time again, is we just don't get long-term colonization as a general rule. There is the odd exception, like there's the odd study. I think there's one using a strain of Bifidobacterium, I think it was AH1206, which isn't commercially available now, but that was able to colonize, I think, in 30% of people for 6 months afterwards. But that is immense rarity, because you can just, if you delve into literature, you'll find that they last for 5 days, 2 days, 10 days, 14 days, but you can see their populations just diminish. If you take daily stool samples, it goes down all that time. And you can investigate this yourself too. You can do a stool test whilst you're taking that probiotic, and then 2 weeks later, do that same stool test and keep every other variable the same. And you'll see that maybe the bifidobacteria was here and then it's not there anymore. It's pretty clear. And as someone that's done a lot of stool testing over the couple decades of my practice, using accurate assessment techniques, is you clearly see that they do not colonize. in these patients. And I think it really cheapens the thought of the ecosystem and care of the ecosystem if we think it's easily replaced just by popping a probiotic pill, because it's not.
What do you think of, and this is something I don't believe that I've heard you mention in the course. I believe it's Bacillus subtilis, spore-based probiotic that is in products from microbiome labs, and they talk about it like it does colonize, and that it sort of takes up residence there, and also that it has an impact on modifying other species of bacteria that are present in the intestines. What do you think of those claims about that?
I mean, I think
species.
The latter one, we know that probiotics do have some impact on the gut ecosystem. Now, I would put that in general as relatively minor. You compare that to changes in diet. You compare that to prebiotic usage. The alterations we get from a probiotic are relatively small. They're not none often. And that can be bigger. Like if it's right after chemotherapy or right after antibiotics, you're going to get bigger changes from a probiotic usage in that case, because the ecosystem is immensely disrupted, and it's more flexible in terms of how things shift at that point. But if you take someone who's a more stable ecosystem, you give them a probiotic, whether it's spore-based or otherwise, the impact will be relatively small. Not nothing, but relatively small. But if you change their diet markedly, you give them a couple of prebiotics, you'll see dramatic changes in that ecosystem. But in terms of the long-term colonization, I haven't seen research to suggest that that's the case. Now, it's possible that I've missed that study, so I'll, showing that there's long-term colonization. Again, doing lots of stool testing over the years, I can't even recall seeing bacillus showing up on stool tests very commonly at all, whether people are taking that when people are taking that supplement, which makes me, whereas I do see bifidobacteria, I do see lactobacilli, that populations do go up and down if people are taking the supplement versus not. That makes you think those show up on stool tests, whereas I haven't really seen that with bacillus, which makes me less, at least at detectable levels, it seems less likely to me that would be occurring.
Okay, so you said a couple things in the last couple answers that I want to maybe clarify. So you said something really interesting, which is that kind of alluding to our microbiome as something unique to us as an individual, something passed down through the generations from our family. And along with this idea that we could take probiotics, but it doesn't really have much of an impact. They don't really colonize. It almost paints a picture of the microbiome as this sort of static, unchanging thing. But then on the other hand, you also alluded to like other factors, lifestyle factors, nutrition, prebiotics, things like that do have a big impact on it. So how do we sort of reconcile, the degree of plasticity of our microbiome? Is it highly changeable, or is it sort of more, it stays like unique to us and it's this thing we get from our parents and we can't do much to change it?
There's a limitation with how much we can change it, I would say, because we get gifted it from previous generations for sure, and there'll be unique strains get passed down your family line, which I think is amazing. And I think what's even more amazing is women's breast milk contains unique sugars that are unique to her that feed those family line bifidobacteria, for example.
Oh wow!
That
I didn't know that.
don't feed other bifidobacteria nearly as well. It's a pretty amazing process when we go into the finer details, and you just get to really appreciate the uniqueness and nuances when you delve into it more. And it also makes you worry about alterations of that ecosystem to a far greater degree too, because it's not easily fixable. And I think that thing of custodianship of your familial line of microbes, if you take that on board, it really changes your choices in life in terms of what you're going to do to that ecosystem. But yeah, so we inherited this ecosystem, and then we can change populations within that through dietary factors, lifestyle factors, and medications. And medications like antibiotics, we know, can cause extinction events to that. So, and many people would argue that with every course of antibiotics, our ecosystem gets less and less diverse. So we can only pass on what we've got. I would be able to pass on less than what my mom passed to me, for example, sadly, because I was dosed tons of antibiotics when I was a kid. I grew up in the 70s where every single sniffle or cough or sneeze, they're like, take antibiotics, take antibiotics, take antibiotics. It was really only when I was in my 18 when I kind of discovered moved out of home and like discovered the world and discovered health, that was like, oh my, I've had almost no antibiotics since then, but it's like, yeah. So
I can still taste the amoxicillin if I just conjure the memory of every time I had a cold, I was given amoxicillin.
Yep.
I know the viscosity of it, the flavor of it, the pink look of it. Yeah.
Yes. Yeah, I know. I've got that very clear in my memory too, sadly. There's this cool study published in Gut a couple of years ago where they were looking at one person's ecosystem, essentially taking almost like daily stool samples, and the ecosystem was immensely stable without any change of diet or lifestyle. Gave them a single shot of, in the bloodstream, intravenous antibiotics. 9 species went extinct.
Wow, even through the blood, through an injection, that's crazy.
Yeah, from a single dose of that antibiotic. And to me, that was just like mind-blowing that we can lose 9 species from a single antibiotic exposure. Yeah, and it caused massive disruptions in this ecosystem. In fact, there was a species that went from like 0.02% up to 96% the day afterwards, that they hadn't even named before, and then they named it after themselves, as researchers often do. Like it was like Bork falkii, ceftriaxone, or something like that, a very funky name. So that was one of the interesting things, was like how much dynamic system there was for the first week or two afterwards. It was crazy dynamic, that ecosystem. Then it settled into a new pattern a few weeks after that, a different pattern than was beforehand. But I think the thing for me is 2 years afterwards, still 9 species were missing.
Wow.
And you're like, oh. And how many antibiotic courses do we get? I had a child patient the other day that had 14 by the time they're 3. And you're like, what's happened to their ecosystem? It's like we've narrowed it down so much. Yeah. So we have things like that. We have proton pump inhibitors. It's widely used class of medications that I've mentioned before increase SIBO risk hugely, but they're selective antibacterials too, that they actually kill bacteria. And they actually decrease the diversity of ecosystem dramatically. And we've got people taking these for years on a daily basis. And again, we're just narrowing this population. So while we were gifted from our previous generations, it gets narrow and narrow in that situation. And we can obviously make certain proportional changes with dietary interventions or our dietary choices. Prebiotics can make pretty major shifts in proportions of microbes. We know that we can have temporary increases in diversity by spending time in nature. Going out for a lovely hike in the woods or in the rainforest, organic gardening, all these things will temporarily boost diversity. And if we're doing it daily, then we get these lovely, continual boosts of diversity that come with that. But they're generally just temporary visitors again. And I mean, it's not to say we don't pick up microbes, because I think we've always picked up microbes from a fecal oral route. If you go back before we had such clean water supplies, we were always picking up microbes from people upstream from us.
We were bathing in polio.
Yeah, or bathing in other people's gut bacteria. And if they didn't have gut diseases, it's like, that's a good way of passing on microbes. When I was visiting Sri Lanka, they have these amazing system of canals that were set up, 1,300 years ago, that go for like hundreds of kilometers. But people are out there, their feces and their laundry and stuff goes into that canal. And it's the way it's been for 1,000 years. And people downstream are bathing in that same water. And yes, if they've got Giardia or Salmonella or something, that's obviously going to be a bit problematic. And it is an occasion, obviously, but it's also a way of passing on microbes. So there are ways of getting some species back in that we've lost, but it really comes to feces exposure, whether that's accidental or whether that's intentional when it comes to things like fecal transplants, where we can regain species in a more permanent way that way.
Yeah, I've been to Sri Lanka and I've been to India, and I've seen some of these scenes of people bathing and doing their laundry in a river with, literally corpses floating through the river. And I picture this as something, and obviously sewage pouring into the river and things like that. I picture this as almost the opposite end of the spectrum of what we do in the West, of giving, the antibiotic courses that you were just talking about. These are people being exposed to all kinds of crazy microbes on a daily basis, whether they colonize or not. There's exposure happening and immune training and all. Who knows what other complex physiological responses there are to that exposure.
Yeah, totally. Thankfully, in Sri Lanka, I wasn't seeing the dead bodies floating downstream. That's another level of microbial exposure for sure.
Mm-hmm. So one other thing I wanted to ask you was, okay, so you've mentioned prebiotics a couple of times.
Yep.
How do we know when to use prebiotics versus probiotics? If you're saying, in general, probiotics, it's interesting what you're saying in the sense that most people, I think, are under the impression that probiotics are really what matters. Probiotics are the things that I need to take that are really going to have an impact on my gut. And most people in general, while this is trending in a good direction, most people in general have kind of brushed off prebiotics as unimportant. Whereas what you're saying, it sounds almost like the opposite. So how do people know, how should they prioritize pre versus probiotics?
Yeah, no, I think you're spot on there in that. And I think it is changing too, as I think you flagged too, is there's a growing understanding of the importance of fiber and prebiotics in terms of tools that we use to make more substantive shifts to the ecosystem. And I don't want to come across as anti-probiotics because I'm not. I use probiotics every day in my clinical practice, but I think it's important that we frame what they do well and what they don't do. And if you're after optimizing your gut ecosystem, prebiotics are far, far more effective at doing that. They're far better at increasing levels of beneficial species and decreasing levels of what we call pathobionts or pathogens. Pathogens are, people are more familiar with their, bad bacteria. Pathobionts are ones that are, in the right amount, are helpful to us, but when they overgrow, they're problematic and cause harm. And we've got a number of those in our gut. And what I love about prebiotics is their capacity to lower levels of pathobionts and pathogens, and at the same time, increase levels of beneficial bacteria. And I think that selectivity of their impact on the ecosystem is just brilliant. So I've used them, since I learned about them, really, which goes back to 2000, 2001. They've been a core part of my clinical practice since then, and they really have been core because I think their capacity to shift ecosystems in dramatic ways is, you can see that. You do the right stool test, and you can see dramatic impacts after 2 months of use on a prebiotic. And if you took a probiotic for that 2 months, you would not see that. There'd be some little shift. It's not to say that probiotics can't help with speeding transit time. They can help with healing up a damaged gut. They can help with decreasing inflammation. There's lots of good reasons to use specific probiotics. But if you're after shifting that ecosystem dramatically, prebiotics or a change in dietary approach will produce far greater shifts.
Very, very interesting. That was a very strong statement that you made, that I think if people really hear that, it will blow a lot of minds and change a lot of perceptions and make people realize that prebiotics, they've really been neglecting and underappreciating the value of prebiotics. I know that was even true of me prior to going through your course. And I had already read a lot about prebiotics. I supplement with prebiotics, but I still was kind of blown away with how you sort of rate the magnitude of effect size in changing gut microbiota.
And I think if you do lots of microbiome assessment with patients pre and post, you see it firsthand, and you see how that correlates with shifts in their energy, their cognitive capacity, and their gut symptoms. And it can be dramatic. I remember I've got one patient who, when I started working with her, she was essentially bedbound. She could barely sit up. She couldn't feed herself. She had to have people feed her. And then to working on a microbiome only level. I wasn't giving mitochondrial support or other things, just microbiome stuff. And we couldn't do much with diet because it was kind of restricted with, because she wasn't in control of her food. She was in an institution and she just got institutional food, which isn't good, as you would know. So we just worked with prebiotics and probably some curcumin or something as an anti-inflammatory as well. But most was with prebiotic work. And geez, I spoke to her just the other week, and she is now in a wheelchair. She's going outside daily, and she's able to feed herself, she's able to sit up. And it's just the difference for her. That might sound like a relatively small thing. It was huge.
Yeah.
huge in so many ways. And she's getting better with each progressing week or month. Things are more functionalities returning. And that to me is one of those cases that demonstrates the huge potential impact that we can get if we change the ecosystem. And her ecosystem was very dysbiotic. It had very high levels of proteobacteria and very low, which are rich with that endotoxin that we started off talking about, and very low levels of beneficial anti-inflammatory butyrate producers. So it was rife for the changing. And we did a follow-up stool analysis, and we reduced the proteobacteria by half, and we increased beneficials pretty dramatically, even though we weren't able to implement all the things, because we had to do very tiny doses, stepwise increase, because her system was so sensitive. Yeah. But even within that context, there was dramatic change. But you can see it, and I think that's the thing too, is you can clearly see the impacts and how dramatic they could be by using a good stool analysis pre and post.
I want to talk kind of I think a natural segue from what you were just talking about, and you've made a couple allusions to the importance of fiber in the diet for maintaining the gut microbiome and prebiotics. So I'm curious, are you aware of the carnivore diet that is kind of trending in some circles right now? And I'm curious what your thoughts are on it.
Yeah, I think it's probably effective at reducing, certain gut symptoms short term, like gas-related symptoms, because you essentially produce a lot less hydrogen gas when you eat only meat. Yeah, because it does get fermented. In fact, it's called putrefaction when meat gets fermented in the gut, and it just produces maybe 1/3 the sort of gas levels what you get when you're fermenting fiber or carbohydrate sort of compounds. So I think it can definitely help reduce symptoms, but I think there's a major trade-offs with that, because you've got to be aware that most, if not all, the beneficial species in our gut are fiber or oligosaccharide or carbohydrate consumers. And if you stop feeding them, their population dips. Not surprisingly, if you stop feeding something, it goes down. And at a certain point, you're going to reach the point of extinction. If you stop feeding things long enough and there's not enough food for them, their populations will eventually just go out. And then it's impossible or really hard, besides a fecal transplant, to bring them back. And as someone who's worked with people that have been on the carnivore and are really unwell and try to get them back, it's really hard work, because part of the other issue here is what they are feeding. It's like, we know they're not feeding butyrate producers, they're not feeding bifidobacteria, and that's really problematic. But what they are feeding is hydrogen sulfide gas producers, because they quite like eating protein and they quite like eating bile, and there's a lot of that in reaching the gut in that kind of dietary approach. And hydrogen sulfide gas causes kind of gut leakiness, but it causes also visceral hypersensitivity, which is when the nerves in the gut are hypersensitive. So you can start feeling even little bits of gas moving their way through, little bits of fiber compounds moving through. You start feeling it.
And logically, it would make sense then that there's a possibility that someone who adopts that kind of diet and then tries to reintroduce plant foods might be way more sensitive to them, and therefore kind of almost insidiously then even more convinced that those foods are harming them.
Yes, exactly. Yeah, and this is where it's really hard to get people off of that, because their gut has now become so inflamed and such severe visceral hypersensitivity that even like a tiniest amount of a substrate, fiber, plant-based food, or that they used to tolerate fine, or a prebiotic, actually causes them excruciating pain. And discomfort. And it's like, okay, how do we work forward? It's really, really slow going, because you have to try to this is where you might use supplemental butyrate. Yeah, because we can't feed the butyrate producers yet because the degree of inflammation is so severe. We have to use lots of gut anti-inflammatories to get to the point where, and we have to use things that help with detoxification of hydrogen sulfide gas to try to initially, before we can start introducing prebiotics, to shift things more positively. But it's really tricky, and this is where I really worry about, is that for a week, yeah, not a big deal, but you start doing this for months, is you start making more longer term impacts to the ecosystem, but also just the environment and the inflammation level that are hard to come back from.
Do you think that there's a possibility, as kind of along the lines of what you were talking about with antibiotics, there's a possibility of sort of extinction events for certain species of bacteria that maybe you can never get back?
I would think yes, but it would probably be time duration dependent. So again, for a short period of time, probably not extinction. Their populations will just go down, but there'll be a point at which you'd expect there to be extinction events, because if you just makes sense, you can't. There'll be a consequence. And when I remember working with one person who was just eating 2 chickens a day. That's all this person ate. And looking at that gut ecosystem, it was like so high in hydrogen sulfide gas producers, so high in bile eaters who create secondary bile acids, which are also pro-inflammatory in the colon, and no bifidobacteria, no Faecalibacterium. I think I was surprised there was 2% of butyrate producers in that ecosystem, which is, I think, one of the lowest I've ever seen. And through a lot of work, we're able to expand things and eventually diet too, for that matter. But I still think that there are some species that will never recover tissues on that diet for long enough that I think there would be extinctions, and the diversity was never going to be as good as what it would have been otherwise.
Yeah. This seems, based on what you're saying, it seems like it has the potential to be a pretty insidious thing, in the sense that a person might adopt this kind of diet and experience only benefits initially, and therefore be convinced that they've discovered the best way to eat, and it's making them lose weight. They're feeling good. They have way less abdominal symptoms, GI symptoms, and the subjective conclusion from that feedback is, I've found the magic best human diet that is going to make me kick butt. And then only later will they start to develop all kinds of other problems, which they probably will not then attribute to the diet that they are convinced is the best diet.
Yeah, no, I think you're totally spot on. Totally spot on there. Yeah.
Okay, so maybe the last, I have like 20 things I wanted to ask you about. The last thing that I want to cover is probably SIBO. SIBO has become somewhat of a controversial thing, and I have personal friends on both sides of this, who some people are sort of in the mainstream functional medicine camp. They're sort of diagnosing everybody with SIBO based on hydrogen breath tests. And then I have other friends, for example, Dr. Alan Christensen, who has written an article that caused quite a stir in the functional medicine community, basically attempting to debunk SIBO as a thing, and he had multiple sort of lines of evidence and logic that he presented to essentially conclude that it's just the evidence doesn't support that SIBO exists and is a cause of IBS-like symptoms and that sort of thing. So what do you, I know this is, I went through 2 hours of lecture of yours on this topic, so I know it's something you can talk
3
about
hours
in enormous depth. But how would you sort of speak to the legitimacy of SIBO and maybe problems with a lot of the testing that goes on with it?
Yeah, I mean, I actually came from the very skeptic camp too, to be honest, because I was doing my PhD in the role of dysbiosis in irritable bowel syndrome when this idea, and this is looking at colonic dysbiosis, and all the research was around colonic imbalance. And then this researcher, Pimentel, presented this idea of small intestinal bacteria playing a role, and antibiotics may be helpful for IBS. And before that, all the research was showing that antibiotics were a common cause of IBS occurring. So I was immensely skeptical when that first came up. So I will flag that, because I'm like, doesn't really fit the broader literature around that. And the only discussion of SIBO was really in before Pimentel's stuff was essentially in people that had short bowel. People had gut surgery, part of the small bowel removed, and they would have raging SIBO, and they'd end up in hospital. So there were cases of SIBO discussed in literature, but it was very much associated with abdominal surgery. That was kind of the thing that we saw with SIBO up until Pimentel's ideas started coming forth. So I was cautious and hesitant about it too, because my area was IBS and it was dysbiosis. Those are my areas. So it was like, this was just and also lactulose as a tool to diagnose it was peculiar to me too, because it was like, I'm using lactulose as a prebiotic, and we know it's a selectively fermented substrate that only some bacteria can eat, and a whole bunch can't. So you're not going to see if those bacteria are present in the small bowel because they can't eat it. So it's going to pass through. So I have some skeptic towards that as a diagnostic tool as well. But you fast forward to 2022, here I am. I actually do believe in SIBO, and I do use breath testing, and I treat patients with SIBO, and their IBS symptoms get better long term, and you can cure people of their IBS symptoms. So I think it's one of those, for me, an interesting journey that's gone along the way as research has changed, as you start trying different things clinically and seeing things. Now, I don't use antibiotics to treat SIBO. I use herbal selectively acting antimicrobials. I use probiotics. I use prebiotics. So a way of altering that ecosystem. But I think for me, it's clear that there are people who do get overgrowth of bacteria in their small intestine. And we treat that and their symptoms go away. Not only gut symptoms, but some people who have brain fog, they get fatigue, aches and pains, those things go too. And I see this every single week in practice. So no matter how much somebody says, I don't think this condition exists, I would say, I see it. I can do pre and post breath testing, and breath testing isn't perfect, and I think if we rely solely on lactulose, we're actually getting false positives and we're getting a lot of false negatives. So it's really problematic if we only use lactulose, which is for me, one of the reasons I was so distrustful of lactulose as a diagnostic tool that I started using. I was always using glucose breath testing at the very beginning, and I started using fructose breath testing, and then I started doing triple breath testing on every single patient I suspected of SIBO over the last sort of 10 years. So you can actually kind of start seeing patterns. And start seeing which sugar substrates I think are more effective for diagnosing SIBO. And I would actually argue from a clinical perspective that fructose is actually a more accurate sugar than either lactulose or glucose. But I generally will do at least fructose and lactulose, or all three, if I really want to get the best chance of seeing if it's there or not. But what we can see is, let's say we have this early rise on fructose. So, there's a breath gas spike at the 20-minute mark. Yeah, and it's extremely unlikely that fructose has reached the colon in 20 minutes. Is it possible in some people? Yes. But in most people in that situation, it's not the case. And then we can treat that person for that, apparent bacterial overgrowth with those selectively acting herbal antimicrobials, pre and probiotic combinations. We can their symptoms go. We can do a retest, and they no longer have that spike in gas at any time point. So we get this objective data showing that is no longer the case, and we get the subjective improvement of symptoms that go with that. And as I said, that's something that I see on a weekly basis. So I have a hard time thinking it doesn't exist when I can see scenarios like that. But I also share some of the concerns that people have about the broader SIBO field, and that not everybody's got SIBO, and I think I have issues too with saying everyone with IBS has got SIBO, and that's clearly not the case. And look at the data around that, and I still don't think we've got the ideal ways of diagnosing SIBO or defining SIBO. I think there's still areas that are open for improvement. Yeah, but I do think there are people who have this early rise in breath gases on sugar substrates, breath testing, and apparent gut symptoms that go with that when we treat that and the breath normalizes and the gut symptoms go away.
Okay, so you said something else in there that I want to flag as interesting. I think it was the case for me, and it's the case for many functional medicine practitioners that I know, that there is a general sort of fear over prebiotics when dealing with SIBO, because these people have this dysbiosis and bacterial overgrowth in the wrong place that's leading often to this reaction to certain kinds of prebiotic fibers.
Yep.
And the tendency in thinking, if I can generalize, is towards maybe like the elemental diet, is towards reducing fiber and avoiding any fiber that could feed the bad bacteria and the bacterial overgrowth. And your course really presented a big shift in thinking, because you pointed to all this research basically showing that certain prebiotics are actually highly beneficial and can help resolve SIBO. So can you just speak to that maybe trend of thinking and why it's wrong and why prebiotics are not something to fear?
Yeah, and I think we could even put probiotics in that too, in that the
Mhm.
general consensus has been don't give probiotics in SIBO because you're already just adding more bacteria to an already overgrown system. But then
Right.
you look at the research data, it's like it's very clear that probiotics are helpful.
Mm.
There's individual studies, but then there was a meta-analysis published a few years back that looked at just grouping all probiotics together, which I think is problematic, but it can still give a general idea about perhaps broad effectiveness. And there's 50% clearance rate of curing of SIBO with probiotic. And given that rifaximin, the main antibiotic used, is like somewhere between 50 to 70% effective, depending on which systematic review you read. It's like not markedly different than that. Yet we still have people saying don't give probiotics because of a theoretical consideration, but they don't look at the research that says, look at the research. It's very clear. And there's some strains that have better efficacy than 50%, but that's just when you get them all combined. And I think too, you look at the research around prebiotics, it's like we know that, let's look at partially hydrolyzed guar gum, which is a fairly unique prebiotic substance because it particularly targets butyrate producing species, I would say. A little bit of bifidobacteria, but mostly butyrate producing species. We know if we give that alongside, let's say, rifaximin for the treatment of hydrogen dominant SIBO, that we improve essentially the cure rate from 60-some% to 87%, by using a prebiotic alongside the antimicrobial. And then we have like methane overproduction, which can happen in the small bowel or colon or both. And we know that giving partially hydrolyzed guar gum decreases methane output with continued use. And following on from that, we know that other prebiotics can decrease methane as well, like galacto-oligosaccharides can as well. Now, we're kind of limited with, there's not that much human research around tools to help decrease methane, but we do have that one study with partially hydrolyzed guar gum. And we have research on we'll go back to the BioGaia DSM 17938 strain of Lactose reuteri, which has been found to decrease methane output as well. So here we have these tools that some people would just say, no, we can't use pre and probiotics, despite the fact we have clinical trials showing that they're actually helpful. And I think that's what I find frustrating, is that when people get stuck in very rigid thoughts around conceptions and theories, that they can't accept the evidence that is being published and right there. And it just means that patients get optimal care because of people being closed and too rigid and not open to new evidence when it comes up.
Yeah. Fascinating stuff, Dr. Hawrelak. I really want to thank you for your time. This has been absolutely wonderful. Thank you for going over our hour of allotted time. And the last thing I want to ask you to wrap up with is and this is maybe a hard question, if you were going to generalize how to best take care of one's gut health, what would be your top 3 recommendations that you want to leave people with?
Avoid antibiotics as much as you can. Make sure you check if they're actually needed. They're still used far too often for viral infections. I wish they weren't, but they still are. Number 1. 2, eat predominantly plant-based. It does not be completely plant-based, it's mostly plant-based. So you're getting and eat a variety of different plant foods. Yeah, so you're having legumes, whole grains, nuts, seeds, fruits, vegetables, multiple colors, because that's what's feeding a diversity of microbes. Yeah, because most of the species in there are fiber and polyphenol consumers. So if we're eating some purple carrots, or eating some black rice, some black beans, we make sure we're feeding a wider diversity than if we're eating, orange carrots only, brown rice only, or white rice only. So it's I think those things to keep are probably the most important. But I would actually tag on like exercise in nature as a way of linking 2 things we know are important. 1 is getting moderate amounts of exercise is important for diversity, and 2, being in nature is is another great way of increasing your ecosystem diversity. So if you can join those 2 together, of hiking in the woods or running through the woods, that I think would be my 3rd on that list.
Beautiful. Thank you so much. And the last thing is just where can people get a hold of you, follow your work, get in touch with you if they want to work with you, or where do you want to send people?
Probiotic Advisor is a good port of call, in that I've got a number of courses online, mostly geared for practitioners, but others for the health conscious general public as well. And then I've also practiced through Gould's Natural Medicine, which is a clinic in Hobart in Tasmania in Australia, even though I don't actually live in Hobart now. It's all virtual these days, but I practice still because I think, and I'm still researching too. And I think that I love all those aspects of things because I think they all feed into each other really well. Is I think working with those patients and seeing the impact is immensely important. Trialing things you see in research and going, does it work in the real world? How do we implement it in the real world to get the benefits? Because yeah, I think is really important. But I think those.
You work with patients all over the world, or just
I do.
Resume? Okay.
No, these for the last 5 or 10 years has been mostly all over the world. Yeah.
Okay, so if somebody wanted to work with you one-on-one, they could contact you. Let's say they're in Canada or in the States or in Europe or something like that, and you could potentially have them get certain testing done.
Yes.
And then you can evaluate them and evaluate the testing and then work with them.
Yeah, very much so. And I would say at least half my patient load is in North America or Europe now. Yes.
Excellent. Well, thank you again so much. On a personal note, I've really enjoyed your course and benefited hugely from it already. And thank you so much for coming on my podcast and sharing your wisdom with my audience. I'm really appreciative of everything.
Oh, you're very welcome. It was a lovely chat, actually. I enjoyed it thoroughly.
Hey, this is Ari again. I hope you enjoyed this episode, and I think you probably can now see why I sought out Dr. Hawrelak to partner with him to create this program under my new brand, humanoptimization.com, why I made him the expert on gut health and microbiome optimization. Again, if this is an area you are interested in optimizing, which it should be, because again, we know that gut health and microbiome health connects with every aspect of our broader health, our metabolic health, our brain function, our energy levels, our mitochondrial function, our body composition, our insulin sensitivity, our performance, our immune health, and so much more. If you are serious about optimizing your gut health and your microbiome health, and you really want to learn the real science, no hype, no BS, no one size fits all sort of kill protocols and reseeding protocols, but just here's the actual real science of how to optimize your microbiome health. I really encourage you to go to humanoptimization.com and get the new course that we just launched with Dr. Hawrelak. I think you're going to be blown away by it. As always, you've got a 30-day refund policy, so you can get access to the course, try it out, see it for yourself, check out the whole thing, go through the whole course if you want. If you're not blown away by the material, feel free to ask for a refund. Of course, I want everybody who gets this course and all my products and programs to be blown away, to be more than satisfied, to feel like they got much more in terms of the value and the results that they got than what they paid for it. That's why I give that 30-day refund window to make sure that that's the case for you. And I think that even if you are a seasoned health geek, like me, who has spent many years studying gut health and microbiome health, and you think you know it all already, I think you're still going to learn a lot from this program. I can say that even for me, as somebody who's been studying health science for 3 decades and learning a lot from lots of gut experts, interviewing a dozen or so top gut experts on this podcast, even I learned a ton from Dr. Hawrelak in the coursework I did with him and in the course that he's produced for the Human Optimization brand. So I'm very confident you're going to be blown away by this and the value you get from it and how that's going to translate into practical benefits in your life. So go to humanoptimization.com, grab yourself the course and enjoy it. Enjoy all the value that you get from it. I think at the end of the day, what we're really talking about when we're talking about optimizing our gut health and our microbiome health is we're talking about how this is going to impact your metabolic health, how it's going to create subtle impacts, or maybe not so subtle, maybe very noticeable impacts and immediate impacts on your brain health and your mood and your brain function and performance, on your mitochondrial health and your energetic performance, how much energy you have. And the broader landscape of things like immune health and metabolic health and risk of various diseases over time. When you look at things on that sort of timeline, how many years of life can this knowledge potentially add to my life? And how much quality of life, how much life is in those years that I've added? How much better mood and brain function and energy and metabolic health and vitality and better functionality and performance in all the systems of my body have I added to my life span because of this information? And when you look at things that way, when you realize this is an opportunity to get essentially the distilled, practical, need to know information about how do you optimize your gut health and microbiome health from one of the world's top experts, I think it's really a no-brainer. So go to humanoptimization.com, grab yourself the course, and I think you're going to be very happy you did. Thanks so much for listening to this podcast. I hope you enjoyed it, and I hope you will take the next step to check out the program with Dr. Hawrelak on gut health and microbiome optimization.